So my name is Ellen Calteau. I'm a registered dietitian and I'm a PhD candidate for Coventry University in the Centre of Intelligent Healthcare. My supervisory team is Dr. Ria Patel and Professor Deborah Lysett. And I'd just like to acknowledge the BDA at this moment and the General Education Trust who have funded my travel to get here today. So I'm going to present my protocol for a feasibility and acceptability randomised controlled trial to screen for food addiction for people living with obesity in dietetic clinics. This one. So a little bit of background. So it is estimated that in England about 28% of adults are now obese and over 36% are overweight. And we also know that there is an interest in food addiction in the research area. In the last decade, the amount of research, if you just search the term food addiction, has increased threefold. So we know that there's an interest there in food addiction. Some of these studies have suggested that perhaps some of these foods can have addictive properties, but the jury's out on what the actual component is, which is causing the conflict in the research circles. And they've concluded that some individuals may have an addiction to some foods. So more recently, with COVID and the lockdowns, we saw some cross-sectional studies, came across some cross-sectional studies, and in Italy we saw that there was an independent association with food addiction and the psychological impact of food addiction symptoms during the lockdown in Italy. In America, they found that those with food addictive symptoms gained almost 5 kilos more than the people without food addictions during their lockdown. So that's that there. This was using the modified Yale YFAS scale, the Yale Food Addiction Scale. And then in Poland, they found when they screened just over 1,000 people, and they found that about 14% of the participants met the criteria using the modified YFAS scale. And the average weight gain for 39% of the respondents was 6 kilos. They also found, though, which has been talked about today, the depression side of things, that those with depression had a statistically significant more food addiction symptoms than the mentally healthy people that had also responded. So just to put into context, though, that those studies are cross-sectional, we can't really tell the direction of causality from cross-sectional studies, but it's still it helps us start to research links. So is food addiction real? Again, this has been talked about already today. There's lots of people saying that it is real, but until it's diagnosable in the ICD and the DSM, at the moment we have to talk about it as if it isn't. But there was a really good paper that piqued our interest that was done at the University of Birmingham by Meadows and Higgs, I think it was. And they interviewed just over 600 psychology students, and just about 300 of them said they self-identified as food addicts and having food addictive symptoms. Then they asked them to fill out the Yale Food Addiction Scale, and they found of those, only 16% actually met that criteria. But it got us thinking that originally half of them have come forward and said, we've got symptoms of this, we have a problem with this, so why aren't we asking about it in our clinics to support them and to signpost them on? And this is where the study was born from. So to go into my study, we're going to use the definition by Gearhart et al., and that is the excessive overeating of high-calorie foods accompanied by loss of control and intense food cravings. And at the aim of our study is to investigate the feasibility, acceptability and potential benefits of dietitians delivering a brief intervention to identify food addiction and signpost to Overeaters Anonymous. And to do this, we have created a food addiction screening tool, which we're calling the FAST intervention. And that was because we didn't know about all the craved, and so we created that one. And the way we've created, well, I'll go into the questions actually in a moment, explain how we've created those. All right, so our objectives. To fulfill our aim, we're going to conduct a feasibility randomised controlled trial of delivering the brief intervention, the FAST intervention, and then we're going to signpost to Overeaters Anonymous. And we're going to determine the effect size of the change of addictive behaviour score, spiritual well-being and weight following the FAST intervention. And we're going to explore patient and dietitian acceptability of receiving and delivering the FAST intervention, and to explore the fidelity of delivery and fidelity of training following the FAST, from delivering the FAST intervention. So the design, as I've mentioned, it's a randomised controlled trial, and we're going to recruit from a university hospital, an NHS university hospital, who have community outpatient clinics, and we're going to approach the tier 3 and tier 4 weight management services. If those are not familiar with that, those are the tier 3 and 4 is where people go before they have bariatric surgery. Tier 4 is bariatric surgery, or type 2 diabetes clinic. Now, I know that food addiction can be found across the weight spectrum. And it does make me a bit sad that we have to do it this way, but a PhD, you only have a small amount of time, and the evidence does say that the prevalence of food addiction is higher in those with obesity. So we've pulled people from those groups to ensure that we can recruit to 40 participants to be able to give us the number later on to go on to a full-scale trial. So the eligibility for our study is to be above 18 years old, have a BMI of over 30, able to provide consent and to read and speak English, and to exclude our exclusion criteria, those not meeting the inclusion criteria, and like many studies that measure weight, we'll also be excluding anyone that's had bariatric surgery within the last 12 months or will be having it in the next 6 months. If they're pregnant or planning to become pregnant, or currently experiencing an active eating disorder. So how are we going to randomise? So we will randomise from the university. We have a statistician who will randomise for us, and we're going to stratify food addiction severity so that the two groups are similar, of the control and the intervention group. The intervention group will get the FAST intervention through the dietitian. The control group will get treatment as usual. Now, the treatment as usual will be whatever it is that they're going to see the dietitian for, may it be the initial appointment or a follow-up. And we're measuring food addiction using the Yale Food Addiction Scale 2.0. So the theory that's underpinning our study is one, if you've worked in healthcare, you may have seen this about anyhow. So it's called the Ask, Advise, Act model, and we often see it in smoking cessation interventions. So the idea behind it is that you very quickly ask, do you smoke? How much do you smoke? Do you want advice on stopping smoking? I'll tell you why it's not good for you. Here's a leaflet. Please consider going to smoking cessation. So the idea is the GP's valuable time, it's very short, and it gives the person the information that they need to decide whether or not to go and access that service. So for us, we're going to ask, do you ever have difficulty controlling your eating or difficulty stopping once started? Have you ever felt desperate for a particular food that you'll do anything to get it? Do you turn to food in the hope that you'll find relief or comfort? And do you ever find guilt, shame or regret after overeating? Now, we got these questions from the binge eating disorder scale and the addictive element part of the YFAS scale, and combined them and just kept it to 4 for brevity for the dietitian. Oh, and the criteria is if they answer yes to any one question, they will then go on to advise. The advice would be an explanation, brief explanation of why compulsively eating is unhealthy for the body and the damage that it causes. And then we will inform the service users of a self-help group specific for food addiction, and we have chosen Overeaters Anonymous. And to act, we will give them the leaflets. Do you eat compulsively? That's what we're going to pass on to them. And what we do, and this is from clinical experience, is really explain that it's signposting and they have to make the move. Because although I've done this dietetically before in the past, and I'd see my patient again in 3 months' time, they'd come back and go, well, nobody wrote to me. I never got an appointment. So it's really kind of making sure that the service user knows that they have to contact Overeaters Anonymous if they want support with their food addiction. All right. So our primary outcome is to explore the recruitment, retention and adherence rates, the length of time it takes to recruit and to get to 40 people, because that's where the feasibility comes into it. So we need to see, is it feasible for us to be able to carry out this intervention at a larger scale and perhaps put it in pathways in the future. So more quantitative data that we'll be looking at as well. We'll be collecting over 3 timelines, baseline, 3 months and 6 months. And we're going to be looking at BMI, the Yale Food Addiction Scale, the 2.0 version, and the Spiritual Wellbeing Scale. I've got a model at the end that shows you the whole pathway that the participants will be taking to be able to go through the study. And then we would go on to fidelity of delivery and training and acceptability. There's no point in inventing or creating an intervention that's just going to sit on the shelf. Is it going to be acceptable to our participants? So there's a qualitative element to this study as well. So we will ask our participants, did you find it acceptable to be asked about food addiction? If not, why not? If so, why so? And then we'll also ask them, how would you feel about being asked every time you came in? Or would you prefer us to just ask you the once and then give you the information and you ask us again in the future when you're ready to talk about it, like we've spoken about earlier? But we also need to see the acceptability from the dietitian's point of view. Do the dietitians find it acceptable about talking about food addiction? Do they feel prepared enough to be able to support the patient? Sometimes when we first start asking these questions, the emotions that come up, have a box of tissues handy, because it could possibly be the first time they've ever said anything out loud. Do the dietitians feel prepared to be able to handle that? And if not, then we can look into providing some training for that and support for them. And as for fidelity of training, the training will be assessed, the fidelity of training will be assessed by the way that we will train the dietitians, so that every dietitian gets the same quality of training. So it'll be a video, so it won't vary. And they'll have a training manual, which they'll be able to refer to as much as they like. And they'll also have a crib sheet with a script. And the idea is that they wouldn't veer too much off the script unless the service user needs a little bit more information to be able to understand. That's how we'll measure fidelity of training. As for delivery, we're going to ask that 20% of the consultations, the intervention part, not the whole consultation, just the intervention part, are audio recorded, transcribed to ensure that they haven't veered off script or perhaps toward the end of the clinic where they start getting a bit tired and maybe they've just been a bit brief. So we're going to ensure that it's been kept as per protocol for the 20% at least of the 40 that we're asking. All right, almost toward the end now. So this is I like this slide because it actually made me quite cross when I was figuring it because the arrows kept moving on different places. So, but now it's finally finished. I'm thinking, oh, I quite like that. So yeah, I like this slide. So this to show you, does it have a light on it as well? Yeah, do we know? Just press the green one because I can't move. Ah, there we go. Right. So to start off. The dietitians will be recruited, they'll consent and they'll get their training session. They will give up to 40 fast interventions, and after that's done, they'll get their interview to test for acceptability and fidelity, acceptability mainly for their interview. At the same time, our admin staff will be looking for eligible participants and start recruiting. We'll get to consent and baseline data. So at this point, we'll be asking for basic demographics and we'll be asking for the YFAS scale, BMI, and the spiritual wellbeing scale. We will randomise at this point now because of stratification. Those that go into the intervention arm will get the intervention, and 2 weeks later, they get a phone call from me asking whether or not the study was acceptable. There's quite a few questions on that. And at 3 and 6 months, they will also fill out, again, the YFAS, the spiritual wellbeing, and their BMI. As for the control arm, they will get their treatment as usual, which is depending on what their appointment is for. They won't get the phone call, but they will also be asked to fill out the 3-month 6-month data for the YFAS, spiritual wellbeing, and the BMI. At the very end of the trial, the treatment as usual group, the control group, will also receive information on Overeaters Anonymous for them to make a decision of whether or not they want to get support with their food addiction. Okay. I broke it. Oh no, I haven't. There we go. So the potential implications of this, well, this study, it's a feasibility study, it will give us those parameters that are needed for a full-scale trial. So the idea is, post-doctorate, we will be able to take this on a bigger scale. And for me personally, what would be really good to see is this going into primary care and before people are getting to tier 3 and tier 4 services or type 2 diabetes clinics, and at primary care level having screening and signposting from GPs, from ANPs, social prescribers. I think that would be a great win, really. So after that, thank you very much. Do you have any questions?